So I want to know about oncoplastic surgery. I mean, we hear breast surgeon only or surgeon, but what is oncoplastic?
Oncoplastic surgery is surgery that combines optimal breast cancer resection with techniques that are related to plastic surgery to achieve a superior aesthetic results. So you're optimally treating the breast cancer and at the same time making sure that the patient achieves a very good aesthetic result of the breast. And that's mainly because majority of early breast cancer patients are curable patients. So we not only want to cure the disease, we also want to make sure that they're psychologically happy, their quality of life is quite good and superior.
So basically, if we break it down, onco is for oncology and plastic is for plastic surgery. And that's why they call it oncoplastic.
Definitely, yeah. Correct. So it's a very specialized hybrid training, and it's not available in all over the world. It's only in a specialized centers when you can combine your techniques for cancer resection to a reconstruction technique to, as Bashar said, you achieve the optimum results to preserve the shape of the breast, the volume of the breast, and also at the same time you have to be oncologically safe, which means that you resect all the cancer, whether it's in the breast, whether it's in the lymph node. And this also will facilitate what we call the adjuvant treatment. So the treatment of the patient after they do surgery. And I have a question to Dana. So how important it is to have an excellent radiologist when it comes to guideline the breast surgeon, the oncoplastic breast surgeon, about what's coming up for the surgery?
Yeah, absolutely. I mean, I think it's a team approach, and I personally feel very lucky to be able to work with 2 oncoplastic breast surgeons in one institution, which is very, very rare at American Hospital. So there's a lot of factors involved with breast cancer surgery. So even if we do detect the cancer early, as you know, it depends also on the location of the cancer, if it's very posterior, for example, if it's involving the muscle, if it's actually closer to the nipple, if there's lymph nodes involved. There's so many different techniques that can occur, and we've had so many complex cases actually together where the outcome was just so beautiful. An implant, for example, wasn't needed because we were able to do flap techniques with the patients, and the patients really deserve to have a good cosmetic outcome. They deserve to have the breasts that they want even after surgery. So I think it's extremely important for teamwork.
Absolutely, I totally agree. And I have a question to Mace. How accessible this information was for you when you were choosing your center, when you were choosing your surgeon? Was that all explored to you?
Yes, but I went to only oncoplastic surgeons. So
very good. Excellent
this is
choice.
why. I mean, actually I did shop around to many doctors, many surgeons. And there were some clinics and hospitals where they had the option of the breast surgeon and the plastic surgeon to be on board together, where they work, as the option of putting out a mastectomy and immediately getting the implants in. But later on, after visiting you and multiple doctors, we agreed that within my case, which I had no idea at the time they existed, to put what you guys call tissue expanders.
Correct, as a stage reconstruction.
Yes,
yeah.
So it's like a mini reconstruction or temporary one until, course of radiation is done, and then get the skin to be more relaxed. So when all of this was explained to me, it kind of put me at ease, knowing that, okay, so I'm not going to lose my breasts. I'm probably going to upgrade them, to better breasts. Of course, it's never going to be the same from case to case, especially having to do mastectomy to the nipples as well. Kind of changes everything. However, it's I could say it's been 3 years, and there's always that final touches that you add, and I think they're starting to look really good. So and if it wasn't for oncoplastic, that wouldn't have been the case. I mean, I highly recommend it.
Well, you're a brave woman. Thanks for sharing your experience with us. And our question to Bashar: what's the changes between, let's say, 30 years ago, breast surgery, and the oncoplastic techniques for the time being?
There has been a huge shift, as we all would appreciate. So with the oncoplastic techniques, we're more ready to take on more challenging cases, where back in the past we would offer mastectomies, for instance. But with oncoplastics, we can actually offer various advanced techniques whereby you can actually conserve the breast with a very superior aesthetic result as well as advancement in reconstruction. So back in the days, it used to be that a mastectomy is the only option with an axillary clearance, for instance, and now majority of the patients are suitable candidates for one form or another of reconstruction, even immediate or temporary reconstruction, which has a profound psychological effect on the patient, and all of that with maintaining excellent oncological results as well. So I think these are the main shifts in our practice over the last 30 years.
Absolutely, and I totally agree, because even the discussion of the patient has changed. So 30 years ago, okay, fine, you're losing your breast, recurrence rate is high, the survival rate is different. But I think with the help of a proper tertiary center breast team, a breast MDT tumor board that we meet and sit together every week, and with the help of excellent radiologists, now we can offer breast conserving surgery to more and more patients in a safe oncological way. Dana, do you want to tell us a bit more about all these targeted resections, targeted lymph node dissection, because we're moving away from axillary clearance, and that's the trend, and the research showing, okay, fine, if you target few lymph nodes, then this will be helpful. So tell us a bit more about like the seed guidance.
Yeah, so we have the option to now localize lesions in the breast and also even localize lymph nodes in the axilla. So instead of having to do a complete axillary clearance, what we're able to do is under either ultrasound guidance or under mammographic guidance, which is X-ray guidance, we can insert a seed into the breast or the axilla. It kind of makes a noise in the operating room, and then this guides the surgeon to know exactly where to go to resect the particular area of the breast or the particular lymph nodes that are under the arm. So I think this has given us so many more options for patients to conserve their breast if they're wanting to do so, in a very, very simple and easy manner, very minimally invasive.
That's amazing technology. Even Dr. Osam, I'd like to know about the scarring, because even a lot of girls are scared about the scars they've seen on old medicine. Very bad scarring, they're big T cuts, and I mean some still do that, but with oncoplastic, I've realized from my personal experience as well that your scarring is bare minimum even when the lymph nodes. Before it was like full going from the lymph nodes all the way down to the breast. Now it's just like very minimum scarring, very slight openings, and you still manage to get a full mastectomy, and with the help of the radiology, just going in and picking out the lymph nodes, trying to put minimum damage on arm movements.
Absolutely. I think, the more advanced the technology, the easier for the operating team, and it's easier for the patient as well. Back in the days, we used to put a wire on the day of surgery, trying to localize the cancer that was not palpable or detectable. Now we moved away from that to do a lot on the day of surgery. Now all these seeds localization by our great radiologists done a week before, 2 weeks before, and sometimes even we do it before the patient starting the journey of chemotherapy, because these seeds can stay for about 6 months giving us signal. So it's just to localize where is the lymph node that was positive before the patient started chemotherapy. So that advanced technology give us the upper hand of, yes, we can treat you safely, efficiently, with minimum scarring. And coming to the topic of scarring, I would like to ask Bashar, so tell us a bit more, what's the difference between, let's say, a standard breast surgeon and an oncoplastic surgeon when dealing with the incisions, with the scarring, with the techniques?
Well, in oncoplastic, the wound planning is one of the basics, and it makes a huge difference, as Maïs has alluded to. So the location of the scar, the shape of the scar, sort of invisible scars sometimes, there will always be a scar, but a scar that the patient can't see or fades away with time. All of these simple points make a huge difference to patients. And I just want to go back to the seed thing. The seed is actually revolutionary because it is, in fact, allowing us to go for precision surgery. So you can get the cancer out, you can get the lymph nodes that we need to take out without collateral damage to areas where we don't need to necessarily resect. And that means lower complication rates, quicker recovery, and again, superior aesthetic results and less comorbidities for the patients. But yeah, the scar is one of the basic oncoplastic principles that has changed throughout the eras.
I can't imagine if I had to remove more lymph nodes than required. I mean, it's probably harder to recover from the lymph nodes than the mastectomy itself. Mobility of the arm, lymphedema, possibility of it. And I wouldn't have ever thought that would have been harder than a mastectomy, but it is. So your job is like, thank you for making minimum damage control. And like you said, precision made your life easier as well.
Correct. Thank you for that.